Hello everybody. I was very surprised to be asked back to present this year, especially after doing last year, so thank you very much for that. Two great speakers to follow, so, wow, don't expect too much from me. So 1 year on from last year's conference, and I remember last year that I was here and I was talking about how much we could do together. If we all get together and work and look at what we're doing and try to make it better, what a difference we can make. And I think that's really, really true. So I've set my slides up today to look at what did I say we would be doing last year? Where did I say the priorities were? And looking to see how much of that we've done. And we don't always get it right. You've heard from Nikki, we don't get it right for 100% of the people, 100% of the time. But let's not forget what a fantastic programme this is. You know, before IAPT, there was nothing. There was a sort of GP-led counselling service that was very sort of postcode lottery. What an amazing service we have. We can always do more. And I'm really passionate about that. We can do more. But look at what we're doing already. So last year I talked about the priorities that the national IAPT programme had. And that was the list. And I've literally taken that from my slides from last year. And I'm going to take you through them one by one to look at where we've moved forward. So one of the priorities was around equality of access for older people, particularly for BME groups. And as a national programme, what have we been doing to support that? Well, we've got the quality premium, which looks at improving access to BME groups and outcomes from BME groups, and looks at increasing access for older adults. We've done a lot of work this year with our clinical networks. Now, there is clinical networks in every area in the country, and I'm sure most of you here today will attend your local clinical network. And we've really been out there talking to clinical networks, talking to clinical leads in their expert reference groups, and really making sure that people are aware of the work that needs to happen. We've put together an action plan with actions against the providers, the clinical network, commissioners, just so people have a reference guide, something to look at and see what can we be doing, what's the learning from other areas that are doing well in BME groups or doing well with older adults access. We've really pushed our awareness campaign, and we've done a lot of work through Age UK. And if you go onto the Age UK website, you will see some interviews with service users who've used IAPT services, and they're really compelling, and you can use those for your service and really push forward the access. And we've done lots of conferences. We had a really successful conference in June in Leeds, and we brought together geriatricians, older adults, mental health teams, community mental health teams for older adults, dementia groups, service users, carers, IAPT teams, and social services. And it was a brilliant conference because those people, like today, and like we've talked about connected with each other and started talking about what they could do to improve the access for older adults, what had been done elsewhere and what really worked. And we've got 2 more of those conferences planned. We've got one in Reading on the 8th of November and one in the Midlands. We don't have a venue confirmed, but we know it's on the 22nd of November. And feel free to email your local clinical network or email me, and I can tell you as much as I know about those conferences, because they will be really, really useful to see what other services have done to improve their access. So that's the quality premium that's in place for 2 years, from this year to 2019. And we know there's 69 CCGs across the country that have signed up to this quality premium for older adults and for BME groups. Oh, it's not working. Okay, I'll press that button. And those are the actions. It doesn't translate well to a slide, and you can't see it, but I'm sure you'll get a copy of slides after today so you can have a look through it. But as you'll see, there are actions for lots of different people, actions for clinical networks that they can be doing, down to actions for services, linking up with your local Age UK group, linking up with any kind of networking group where older people congregate so you can increase access. And moving to ethnicity, we can see that the rates of referral for 2015-16, which is the latest yearly report we haven't got 16-17s yet, it's fairly shocking, really, when you look at the rates of referral for specific BME groups. And that's something that we really need to be thinking about. How can we improve that? How can we ensure that equity is across the service and that people who enter IAPT services do as well no matter where they're from? And those are similar actions for around ethnicity for clinical networks, providers, commissioners. So one of the other priorities I talked about last year was improving the quality of services. And as Nikki said already, we have met the 50% target recovery rate for IAPT for 6 months in a row now from this month. So we've just got June's data, and it shows that we've met 50% now for half a year, which is an incredible improvement. But it's also the work that you've been doing in your services. I can't stand here and say I've done that. You've done that. You've worked on it. There's been a real push, especially in the north of England. And the number of CCGs hitting that 50% target now are much higher than they were before. And the number of CCGs with recovery rate lower than 40% is now in the single figures. So I think there's something that we really have to be proud of. And the other way we're looking at improving quality is by making sure that there is information out there on what IAPT is and what it isn't. So I think over the last 10 years, IAPT has changed. It's grown, it's learnt, but it's also drifted in some areas of the country, providing things that the staff are neither trained nor competent to provide. And I think that's put a real stress on the workforce. So what we've done with the aid of NCCMH, which is the National Collaborating Centre for Mental Health, is we've put together an IAPT manual which talks about anything to do with an IAPT service, how to run one, what the workforce is, what treatments it should provide, who can be working within an IAPT service, waiting times, anything you can think of about IAPT is in there, alongside staff well-being. And I think it's going to be really important to get this out in the system. We're hoping that it will be published in October, possibly late October, early November. But when it does hit the system, it will be a clear document to show what IAPT should look like. So one of the other things I talked about was improving the productivity of services, and that's not about making the staff you've already got work harder. We don't want them to work harder. We know people are working at capacity across the system. What we need to do is find a way for them to work smarter, and partly that may be to do with digital products, and how do we make sure that that choice of the way that treatment is delivered is offered across the country. And I won't say any more than that because I know that James Woolard from NHS England is going to be presenting on digital a bit later. So the other priority I mentioned last year was around supporting the implementation of activity and outcomes-based payments, or tariff payments in IAPT. It is a national policy objective, recommended that it's linked very much to outcome-based payments using the 10 national outcome measures that are collected within the IAPT minimum data set. But there is some flexibility around that, and local areas can look at the guidance and decide how best it would work for their area. But this is about improving the quality of services and improving the sustainability of the workforce. So thankfully today we have with us Becky Minton, who has been recruited by NHS England as a workforce wellbeing project manager, working with the team to scope the work that's been done so far on wellbeing of staff, to do a literature review. She's been working with HEE, she's been going to clinical networks, she's been talking to services. She's also written a section in the IAPT manual on wellbeing, and she is here with us today, and I'm going to ask her just to stand up for a second and wave, because if you have any information about wellbeing and how it works in your service and have good things to share, she is the person to talk to, Becky. So that's Becky. Bless her, she's going to kill me later. What else were we doing? We were looking at IAPT LTC. Now, I've said that quite slowly because we were initially last year calling it Integrated IAPT. We are not allowed anymore to call it Integrated IAPT. It upset a few people in the health community. So now we call it IAPT LTC. But you'll see my slides are so rubbish that I interchange between the two. And I'm not very politically correct, so I'm bound to get it wrong throughout this presentation. But this is one of the main 5-year forward view commitments. It is about increasing access from 15% to 25% by 2020-2021. And 2/3 of that increase in access should be on these new IAPT LTC integrated services. And these services are about being integrated in physical health pathways for people with long-term physical health conditions or distressing and persistent medically unexplained symptoms. And a number of areas are already implementing this and developing their own services. And I think it's really crucial to say that this is a very systemic change. This is a culture change. Having to work with other professionals, especially in physical healthcare, is not particularly what IAPT has done before. IAPT has done really brilliantly, doing its own thing, slightly outside of the rest of the system. So this is quite a challenge for us. So in 16-17 last year and this year, we had a number of early implementers who have been supported centrally to provide IAPT LTC services. Why are we doing it? Well, we know that the number of people who have depression and anxiety who already have long-term conditions is quite high. We also know that they're already being seen in IAPT services across the country. We also know, and there's a suite of evidence to show this, that if you treat the emotional difficulties and anxiety and depression of people with long-term health conditions, that in the longer term, it saves health costs by around 20%. And what we do know also is that the best outcomes come from modified treatments. So people who enter into a standard core IAPT service with long-term health conditions may not do as well without having a modified form of that treatment. And that shows from the national data. Currently, the national data shows that there's a 3% difference between the overall recovery rate and the recovery rate for people with long-term health conditions. What we're finding from our early implementers is that that difference isn't there, and the recovery rates have been quite high. Medically unexplained symptoms, they're very common, and they're also very disabling. And people with medically unexplained symptoms are frequent users of health services. There's been various studies and there is an evidence base to show that psychological therapies are effective, and they mainly work on CBT principles and build on the core competencies of the IAPT workforce. But The new top-up training that we have developed for long-term conditions includes additional bits of information and additional procedures that the IAPT staff can use when working with this cohort of people. An engagement in treatment for people with medically unexplained symptoms can be difficult, but the rewards are huge, both for them and for IAPT services. It's really crucial that people have access to the right treatment at the right time. So what have we learnt so far from what we've been doing with these early implementers across the country? Getting outcome data is absolutely crucial. I understand what Nikki was saying around it felt like a tick box exercise, and I think we should really discourage that. The data is so rich in IAPT, not just for us looking at outcomes and overall targets, but for a therapist knowing how somebody is progressing, using the scores as a way to guide your treatment, and looking at the scores and saying, oh, that's interesting that so-and-so has dropped or got higher this week, and having a conversation with the person, bringing the scores, bringing those questionnaires into the therapy room. If it's done well, it's really, really crucial and useful. The pilots that we had previously, so we had some Pathfinder sites across the country around 2013. They fell below the standard and they weren't collecting the outcome measures that we really wanted. So we haven't got as good an idea from those Pathfinders as we thought we would have. And I think that wasn't the fault of the Pathfinders, that was the fault of the system. It was a systemic issue that we suffered at that point. But our integrated services now need to collect additional data on the impact of the long-term health condition and the healthcare utilisation. So we're using the CSRI to follow that information, to find out if somebody's use of healthcare services has reduced as a result of having IAPT interventions. But it's very important to be clear from the beginning about what we're collecting and why. And how the data completeness is monitored, and also explaining that to the people that we're offering treatment to. So what's our definition of an integrated, there, I did it, I knew I would do it, of an IAPT LTC service? It's a service that will expand access to psychological therapies for people with long-term physical health conditions or medically unexplained symptoms by providing care genuinely, and I'll repeat that, genuinely integrated into physical health pathways, working as part of a multidisciplinary team with therapists who've trained in the IAPT LTC top-up training, providing evidence-based treatments co-located with physical health colleagues. And that is so important. How many of you value those corridor conversations that you have with people, sort of impromptu supervision sessions, just discussing a patient or a challenge that you've had recently? The same is true for our services working with long-term physical health conditions. The co-location and the integration of two services together is what makes it different, is what makes it special, both for the therapist and for the patient. The fact that this is business as usual, part of their normal care package that they would get for their coronary heart disease or in the breathlessness clinic. You know, the fact that this is part of what is provided to them already is so important. So our early implementer program consisted of 22 areas covering 30 CCGs in Wave 1, 15 areas covering 38 CCGs in Wave 2. And I won't go through it, but we did a huge amount of work, both before the program started and we're still doing it now. We've done visits to sites, implementation calls, delivery calls. We've had workshops. We've got the evidence-based treatment pathway integrated IAPT LTC guide, which is similar to the IAPT manual, but for LTC services. We've also commissioned an evaluation of the EI sites, so Wave 1 and Wave 2, looking at the how they provide the service, the what was provided, but also the outcomes and the savings. What have we learnt from doing this so far? Well, the process was an absolute nightmare. The document that we gave people to fill in to bid for the services, well, you've never seen anything like it. I've never seen anything like it. It was difficult to understand. It was fairly difficult to read. We gave people about an hour and a half to fill it in before they had to return it back to NHS England. Yes, that's a slight exaggeration. And then we had our finance colleagues look over it, and then we got it back about 12 weeks later. So it was tricky, and I think my learning from that is to be upfront with services right at the beginning and talk to them, even when we're told we can't say anything. I think the more information we get out there, the better. It's so important, because I think what we found is those services and sites that we were able to communicate with and have conversations prior to, during and after the bidding process have done much better. We also know that there's a lot of concern and pressure generally across health at the moment, because the financial position is so tight. So there's a lot of risk inherent, even though it's in the planning guidance, even though from April we need all services across the country, all CCGs, to be developing their IAPT LTC service. We know that it's a struggle. We know that lots of CCGs are in crisis. But I think the fact that it was in the implementation plan, in implementing the 5-year forward view, it gave us the leverage we need to move this forward. And there must be good evidence for it, or we wouldn't have squeezed that money out of the government to do it in the first place. So what have we learnt on the commissioning side? Well, the commissioners have told us start early, plan early. Engagement, relationships and development of these services, it does take time. Actually finding out who to talk to takes time. And then when you actually get hold of them to talk to them, understanding what their pressures are just as important as putting across what the IAPT pressures are. Developing a good implementation plan which is co-produced. So co-produced by physical health commissioners, physical health teams and staff, along with mental health, IAPT services, anybody working in that space that you're moving into, but also with service users. We've got some of our early implementer areas who are doing fantastic work with their local diabetes group, coronary heart disease groups. There is amazing work going on out there, but the commissioners tell us that you have to start it early. Think about future-proofing the investment. We've got one service out of all of our early implementers who've had their finances agreed for 3 years, so they know where they're going. Many of the others are still struggling to make sure that from next year their service will continue to be funded. Developing pathways, you need to look at the local nuance and what's important in your local area. Some areas have much more diabetes prevalence than others, and I think use that to guide decisions of which pathways you want to integrate. And some of our commissioners said that they were so surprised when they did a mapping exercise of what was actually being commissioned in their areas to find that there were pockets of emotional support, of psychological therapies or health psychology that they didn't even know existed beforehand. Lots more learning from commissioners, particularly around GP champions, patient focus groups, and making sure that there's clarity between all of the services working in the space. So if you're working with a liaison team, understanding what the boundaries between what you do and what they're doing. The providers have told us you need to start early. Engagement, relationships and development of pathways takes time. So you'll see I've repeated that. It'll probably be repeated again, but it takes longer than you think it will to develop those relationships. Make links top down and bottom up, and that means your links with the teams that you will be working with on the ground are important. They're crucial, but also the links that your commissioner can make with other physical health commissioners are just as important. And you need that two-pronged attack to be able to make sure that referrals come through and that all areas know what's happening. And cast your net widely. If you get a no in one space, move on to another. Keep asking the same questions. Eventually you'll get there. Some of our early implementers have taken more time than others to make those links and get the referrals through. Don't underestimate the importance of publicity and marketing. I'm a terrible tweeter. I tweet all the time, and if you see my tweets, usually over the last few weeks it's been about IAPT LTC, and we're currently going around the country doing commissioning IAPT LTC events, and that's all I'm tweeting about, just constantly tweeting about IAPT LTC. Publicity is so important to get people to start talking about it. Branding services. Interesting, a number of our services have lost any kind of reference to mental health. And it's not just about parity of esteem, but it's about making sure that the people who you need to access the service. And if in your area people with diabetes would link much more to emotional well-being than mental health, then that's sometimes the reason why services have chosen to do that. Using alternative language, training physical healthcare staff, dual training practitioners. This is all learning from our early implementer sites. So in Sheffield, they did a fantastic thing. They have trained the physical health staff who are working as OTs in some of the physical healthcare pathways in the IAPT Step 2 and Step 3, so that they are dual trained and they're working across both services. Really great idea, very clever. Be clear on the design. This is not a signposting model. This is genuine integration. And think about how you sell this to the physical health colleagues to demonstrate the benefits, because I think what we've found is that staff in A&E, where our services have tried to integrate in some way with A&E, have just been too busy to be involved in this at all, whereas a little further down the line, perhaps community care has worked much better. What are our headline figures? Oh my gosh, 2 minutes. I've done about 400 slides. You'll be here all day. So in 16-17, 130 PWP trainees were recruited as part of the expansion, 172 HI trainees. We've done a lot of CPD training, and over 3,000 patients were seen in our Wave 1 early implementer sites. For 17-18, we're planning to see over 45,000 patients. Lots of training as the year before, lots of top-up training happening, and we've also had a universal offer with HEE, so that where there have been extra places available on either the top-up training or core training, we've tried to encourage services who aren't part of our early implementers to take up some of those places. So this links us to the other commitment that we have, which is the 3,000 extra mental health therapists in primary care. And we couldn't have done the work that we've done so far without the help of Maiden, who have really supported us following a panicked phone call on the train from Paddington, Chris and I, when I said, look, I need you to do something and I need it tomorrow, really. And what they've done is they've worked with all of the services using IAPT to look at how activity is being delivered and where it's delivered, looking at location codes to give us some kind of baseline to understand across the country. I'm not going to finish in time. I'm just not.
You've realised that's the main thing.
Sorry. And now we've got a baseline for 15-16, so we can see how that pans out. Now, our commitment to these 3,000 mental health therapists came a bit off the wall. We didn't know this was happening, so this has been quite a surprise for us. But they won't just be IAPT therapists. There will be other teams and services moving into primary care, so maybe from secondary mental health care, which is great, but we need a way to measure who those people are and what they're providing. So we've done this calculation using the data that Maiden provided us. It's based on very simplistic assumptions at the moment. We're going to share that with regional colleagues and use it as a starting point for local intelligence to build their workforce plans for the next 3 years. And I'm sure it will change, and I'm sure next year I'll be coming here saying something slightly different if they invite me back. So our biggest challenge to come is ensuring rollout of the IAPT LTC services across the country from April. As I said earlier, we're doing these events in every clinical network and we're racing around the country like you've never seen. Next week on Tuesday we're in Gatwick and on Wednesday we're in Durham, so it's going to be a long night on the train. And the reason for that is to make sure that commissioners are aware that this is a commitment. This is a commitment we need to meet. We know that there is some concern around financial stability in the system, but actually, why wouldn't you do this? Why wouldn't you create an IAPT LTC service for people so they get the right care at the right time, which enables them to manage their physical health care better and possibly save them huge difficulties down the line? So we've got a suite of guidance we're providing, and we're happy to provide it to anybody who wants it, which include FAQs on which have sort of been created through our early implementers, through the bidding process, and things that have come up on our Yammer's sharing site. We've also developed the evidence-based treatment pathway that I talked about earlier within CCMH. We've got a document which talks about how to develop a business case around providing this. We've got a very nicely sort of more friendly document that's our how to develop an integrated IAPT service, which doesn't read like something that you'd expect to come out from NHS England, and it's not branded, so it hasn't come out from NHS England. We've also got a local evaluation guide to show how you can evidence savings in your local area, and a data handbook which gives all the information about the new measures that are being collected. So we've still got a long way to go, we've still got a lot to do, but we wouldn't be stood here doing it without you. Thank you.